Let's start with dementias today. So see, I know that dementia is everybody's fear in MBBS, but let me tell you something. Dementia is the most important and the easiest topic in neurology. The reason being that we have very handful of dementias and there are particular criterias or symptoms and clinical features for each dementia. You can't confuse one with another. They're all different. So that's how it makes it very easy. I'll try to make it easier for you. Right? So let's start. Let's start. So here it is 4 a.m. right now in my watch. So if I can do it, if I can wake up early, see, early morning studies are always the best. If I can do it, you can also do it. There is no distraction, कोई शोर शराबा नहीं है, कोई आवाज नहीं आती. It is so peaceful. During my NEET PG entrance preparation also, I used to wake up at around 2:30, used to study till 7, and then I used to rush back to college for internship duties and everything. So those 5 hours were the most important hours out of those 24. Make use of it. If you are an early riser, very good. If you are not, try to shift your night time, your sleep routine a little bit early and wake up routine also a little bit early. It helps a lot. Trust me. So let's start with dementia. So when we talk about dementia, by dementia we mean memory loss, right? This is what comes to our mind. But dementia is not just about memory loss. There are different domains, there are different cognitive domains which play a role in dementia and they play a major role. So we will first start with the various types of dementia, then we'll move on to the lobar functions. We will also see what all lobar functions are there for different lobes. So let us start with the questions that are usually asked. All right, so you are asked about cortical versus subcortical dementia. Now, cortical dementia, as the word suggests, cortical means cortex involvement. So, if this is an axial section of the brain, the gray matter is the outer part, and then inner part we have the white matter, and then we have the nuclei like basal ganglia. These are the deep nuclei, and we have the ventricular structures, right? So, if we talk about the cortex, so this gray matter is the cortex. The outermost part of the brain is the cortex, and as we move inward, we are moving inwards towards the white matter, and that is the subcortex. Now, the features of subcortical involvement and the features of cortical involvement are completely different, and hence we need to differentiate between these two. So, there is a mnemonic for subcortical dementia. The mnemonic goes like primary healthcare worker, primary healthcare worker, and you can add 3 and 2 here. So what is P? So we have 3 P's, then we have 2 H, and we have a W. W is for Wilson's, 1 H is Huntington's, 1 is HIV, Parkinson's disease dementia, PSP, and of course PMLE. Multifocal, progressive multifocal leukoencephalopathy. See, the word in itself tells you leuko means white matter. Encephalopathy is involvement of the brain structures or the tissue. So PMLE is a subcortical thing. So PMLE, PSP, PDD, HIV, Huntington's and Wilson's are subcortical dementias. Now what are left? We are left with cortical dementia. So Alzheimer's dementia is a cortical dementia. Pick's disease is a cortical dementia. Pick's disease is a cortical dementia. So please try to remember this. These are important questions. Okay, so for your NEET PG, this is also an important question. This is how you can try to remember this. Now let's move on to the pathophysiology. So certain dementias, there are certain dementias which are occurring because of involvement of tau bodies, and some have synuclein pathological inclusion bodies in the cells which lead to degeneration of those brain cells. So we divide these like taupathy and synucleinopathy. Taupathy and synucleinopathy. Nucleinopathy. Again, an important question. So in order to remember what all dementias are taupathies and what all dementias are synucleinopathies, again we have a mnemonic. So for synucleinopathies, the mnemonic is PDM. Padho Daro Mat. PDM. Padho Daro Mat. Right? So P stands for Parkinson's disease dementia. D is dementia of Lewy bodies. And M is multiple system atrophy. MSA. MSA. Right? So PDD, DLB, MSA. Synucleinopathies. And if we talk about taupathies, now for taupathies, we have a mnemonic. I made this mnemonic for you, ACP Faridabad. ACP Faridabad. ACP and F. Right? So A, with A, you know what is A. A is Alzheimer's disease. And right, C is CBD, corticobasal degeneration. P is PSP. And F is frontotemporal degeneration, FTD. F is frontotemporal degeneration, FTD. Okay. Try to remember these mnemonics. So we have read 3 mnemonics till now, and the mnemonics go like one is for synucleinopathy, PTM, Padu, Darumat, and then one is for taupathy, that is ACP Faridabad. The third mnemonic was for our subcortical dementias, primary healthcare worker, PHW. So 2 important questions covered. Did not take much time to. Moving on to Alzheimer's disease. Alzheimer's is the most common dementia after 60 years of age. See, there is an early onset Alzheimer's, early onset AD. There is a late onset AD. Early onset AD is Alzheimer's that starts with the onset less than 65 years of age, and late onset AD is the Alzheimer's that starts with the onset after 65 years of age. After 65 years of age. Right? After 65 years of age. Now, the most common cause of dementia after 65 years is Alzheimer's disease, or in elderly is Alzheimer's disease. And in Alzheimer's disease, there is a typical sequence that is followed for clinical features or as far as dementia is concerned. So usually we talk about the language dysfunction. We know anomia is there in Alzheimer's. So in Alzheimer's, we have first memory gets impaired. So there is forgetfulness. Patients start forgetting. So memory. Followed by language impairment. In language impairment, there is logopenic aphasia. Now, as the name suggests, logopenic. Penic means, penia means less. So a deficiency of logo. Logo is like names, logos, like things have logos, cartoons have logos, right? So names. So a deficiency in naming, anomia, right? So it starts as logopenic aphasia. Logopenic aphasia means there is a naming difficulty. Anomia, there is a naming difficulty. People start forgetting names. For example, if I ask them what is this, so they might not say that this is a pencil or a pen. Or if I ask them, better will be this. If I ask them what is this, they will say it is something that we write with. They will not be able to figure out the name, that it is called a pen, right? So that is what is logopenic aphasia. There is difficulty in naming and also in repetition. So that is one thing. After language comes in visuospatial. Visuospatial means GPS. हमारे brain का जो GPS है वो हमें visuospatial perception देता है. So they start forgetting their ways. Instead of going to the washroom, they'll enter the kitchen first and then realize they're not in the washroom. Or if they go out to the park or somewhere, they are not able to figure out the way back home. So this is how Alzheimer's progress clinically. And this may take years. Alzheimer's is a chronic, very slowly progressive illness. It is not a very fast, rapidly progressive dementia. It is a very slow progressive dementia. So here we'll try to remember the early onset, late onset Alzheimer's. We'll try to remember that it is the most common cause of dementia in elderly. We'll try to remember that it starts with memory loss, it moves on to language involvement, and then it moves on to the visual spatial involvement. Now, memory and language are two functions that are related to the temporal lobe, and visual spatial or our GPS is in the parietal lobe, the non-dominant parietal lobe, right? So try to remember that too. Now, when we talk about Alzheimer's, we also have certain types of Alzheimer's. There's a typical AD. Then there is a posterior cortical atrophy variant. Then there is a frontal variant. And then there is a CBS, a corticobasal variant, a corticobasal variant. Now, typical AD, as we just described, starts with memory, forgetfulness, moves on to the language, naming difficulties, and then the visual spatial thing. In posterior cortical atrophy, posterior means parietal. So remember PCA is parietal cortical atrophy, right? So it starts with visual spatial. It starts with visual spatial disorientation. It starts with difficulty in finding ways. Then there is a frontal variant. Now this, of course, is the most common variant of AD. Frontal variant, as suggest, as it has been written, frontal. So frontal lobe is mainly for insight, judgment, and behavior. So there are behavioral disturbances. Usually in typical Alzheimer's, behavioral changes are not there. Aggression or trying to run away from home, uh, um fighting with everybody, or a change in personality is not there in a typical AD, but in a frontal variant, there can be behavioral changes along with memory loss. Along with memory loss, there can be behavioral changes that start with. And CBS is, of course, dystonia. So when we see corticobasal, we talk about dystonia because see corticobasal, cortex involvement means aphasia or paraphasias, language impairment, and basal ganglia. Basal ganglia is something, is a structure that is related with movements of our body. So when we say corticobasal syndrome, we also talk about including a movement disorder, typically dystonias. And corticobasal syndrome is asymmetrical, typically asymmetrical. So asymmetrical dystonias along with memory loss. It can be a CBS variant of AD. It can be a CBS variant of AD. Now in exam, a typical AD is asked and then PC is asked. So we try to remember that. Now there is something known as MCI, mild cognitive impairment. See, dementia, we only call dementia. There is MCI, mild cognitive impairment. Mild cognitive impairment. Mild cognitive impairment. See, in dementias, we know that EDLs are affected. In MCI, EDLs are preserved. EDLs are preserved. And what do we mean by EDLs? EDLs are activities of daily living. Activities of daily living. So there can be basic EDLs, there can be instrumental EDLs. Basic EDLs are taking bath, eating, having the food, dressing up. That is basic activities of daily living, going to washroom on their own. Instrumental EDLs are doing something like cooking, shopping, going to the mall, exercising on their own. Those are all instrumental EDLs. So whenever there is memory loss, forgetfulness, or difficulty in finding ways, or a language issue, or any cognitive domain is affected and the activities of daily living are still preserved, right? The person is able to find their ways home, the person is able to take bath on his own, is able to dress up, is asking for food, is able to eat on his own. We call it mild cognitive impairment. We do not call it dementia. Dementia is when the activities of daily living are also impaired. So mild cognitive impairment, people with mild cognitive impairment, this is the question. 50% of patients progress to Alzheimer's disease over 4 years. So the rate of progression is 12% per year. 12% per year progression. So 50% of, if you see 10 people coming to you with memory loss but ADLs are preserved, so 5 out of those 10 people are going to progress to Alzheimer's over the next 4 years, right? And this is something that you need to know. This is why it is asked specifically in INICET. This is a very important question for INICET. The AIIMS really focuses on prognosis of illness, or what do you explain to the patient in OPD. So INICET questions are also based on a similar thing. So this is an important question for your INICET 25 exam, correct? So now if we talk about the investigations, sorry. So we talk about the risk factors first, then we'll talk about investigations, and then we'll talk about the treatment part. I'm not able to reduce the size of the pencil. So if we talk about risk factors, the main risk factors that we have is age above 65 years. So, and diabetes mellitus increases the risk of Alzheimer's 3 times. Then we have females more predisposed to Alzheimer's as compared to males. Family history in a first degree relative. Family history. Trisomy 21, Down syndrome. Certain genetic factors. So APP gene, the genes that are involved are APP gene. Then there is presenilin 1, then there is presenilin 2. Chromosome 21, 14 and 1. 21 and 14 are multiples of 7, so easy to remember, right? So trisomy 21, APP gene, ApoE4 allele, chromosome 4, 1 and 4, 21, 14, 1 and 4. So you can remember it like 14, 1 and 4, right? 1 and 4. A positive family history increases the risk of Alzheimer's by 2%. So out of 100 patients, 2 may be having a genetic link or maybe having a positive family history. This is what we mean by this. So these are the risk factors. Important question that is asked is, smoking is not a risk factor, for Alzheimer's. This was asked 10 years back. I'm not sure if they ask it now. Did not find this question in the recent 5 to 6 years question papers. But yes, it has been asked earlier, so let's be prepared with it. So smoking is not a risk factor for Alzheimer's disease. Now, if we talk about MRI, what are the findings in MRI? As I told you, temporal and parietal lobes are the important lobes that are involved in Alzheimer's. It's not the frontal lobe, it's the temporal and the parietal. So what we see is a temporoparietal atrophy. A temporoparietal atrophy mainly involving the medial temporal lobe, the medial temporal pole or the medial temporal lobe. Cortical atrophy. We usually get MRI done in a patient of dementia to rule out secondary causes like an infective cause or a space occupying lesion or a stroke. So to rule out the secondary causes of dementia. If we talk about PET, so when we say PET, we mean an FDG PET. If we talk about PET, there will be a hypometabolism. There will be a hypometabolism in the temporoparietal area, hypometabolism in the temporoparietal area. Now, amyloid PET is a very specific investigation for AD, more specific, right? It finds out the amyloid deposits. We'll talk about the pathogenesis also, but this finds out about the amyloid PET is a very specific investigation for Alzheimer's. If we talk about CSF, so please try to remember that A beta 42 levels in CSF go down, right? So I usually try to remember this with the mnemonic AD. In Alzheimer's, there is a decrease. In Alzheimer's, there is a decrease, AD. In Alzheimer's, there is a decrease in A beta 42. There is a decrease in acetylcholine levels. That's why we give acetylcholinesterase agents, right? So they increase the acetylcholine levels. So CSF A beta 42 decreases. Now, the earliest degeneration that we find in Alzheimer's is in the medial temporal lobe, the entorhinal cortex. The entorhinal cortex is the first part that is involved, and nucleus basalis of Maynard are the cells or the tissues that are usually involved. Now, if we talk about treatment, we talk about acetylcholine levels. Acetylcholine levels decrease in ED, so we try to increase the levels with acetylcholinesterase inhibitors. Acetylcholinesterase inhibitors. Acetylcholinesterase is an enzyme that cuts down acetylcholine. So if we give acetylcholinesterase inhibitors, if we remove acetylcholinesterase enzyme, obviously the acetylcholine will not be broken down and it will increase. So we are trying to increase the acetylcholine levels by giving acetylcholinesterase inhibitors. So among all the acetylcholinesterase inhibitors, we have one is donepezil, then there is rivastigmine, then there is galantamine, right? And then memantine. Memantine is not an acetylcholinesterase inhibitor, it is an NMDA receptor inhibitor. It is an NMDA receptor inhibitor. They also ask about the doses, so let us try to learn the doses. So donepezil is 10 milligram once a day, while memantine is 10 milligram twice a day. Rivastigmine also comes in the form of a patch, so you can either give in an oral form 6 milligram tablet twice a day or a 9.5 milligram patch daily. Galantamine is 24 milligram once a day. So these are the dosages. These are the dosages for Alzheimer's disease. Now let us put this over here and let's talk about the pathology. Let's talk about the pathology. Pathology behind Alzheimer's disease. So when we talk about pathology, we have neuritic plaques, we have amyloid angiopathy, and we have neurofibrillary tangles, NFTs, neurofibrillary tangles. I will write that down for you. So it is neurofibrillary tangles, right? So when we talk about neuritic plaques and amyloid angiopathy, this is all related to amyloid. What happens is there is an amyloid precursor protein. There is an amyloid precursor protein, and this protein is supposed to transform into amyloid. Now, this protein is not supposed to transform into something that damages the brain cells, but it is thought to be a neuroprotective agent for the brain. But what happens is that sometimes in some people, because of these risk factors that we discussed, because of the age or because of family history, there are beta and gamma secretase levels that increases. Beta and gamma secretase levels. Now, as these are enzymes that break down APP, they break down APP into A beta 42 abnormal amyloid. And now this amyloid get deposited and they lead to both the neuritic plaques and the amyloid angiopathy. Neuritic plaques and the amyloid angiopathy. And when we talk about neurofibrillary tangles, this is more about tau. So tau is an agent that binds to microtubules in these axons and it provides nutrition to the axons, right? So tau is something good again. But then, due to the risk factors, tau gets hyperphosphorylated, and when this phosphorus gets stuck to tau protein, the hyperphosphorylated tau is not functional anymore. So it leads to axonal death because now the cellular axons are not able to get nutrients. So this leads to axonal death and leads to formation of neurofibrillary tangles. Now when the cells die, they are obviously going to get converted into something. Neurofibrillary tangle is something that they get converted into. So these are the neurofibrillary tangles. Now the most common commonly or the first affected structure are the cholinergic neurons. What are the neurons that are first affected with this amyloid and hyperphosphorylated tau are cholinergic neurons in nucleus basalis of Maynard. Nucleus basalis of Maynard. Okay, so try to take a screenshot. Let's have a water break and come back in 1 minute. Okay, and one important thing that we forgot, cerebral amyloid angiopathy, CAA, is also a risk factor for Alzheimer's disease. Please remember this. Again, INICET के लिए बहुत अच्छा question है. Will be asked because we used to see lots of patients of cerebral amyloid angiopathy at AIIMS. So the cases that are usually seen there, that we see there, are the questions that are asked. That's why cracking DM after doing your MD from there is very, very easy. Because you know that these are the questions or these are the topics or these are the cases that are usually seen. Cerebral amyloid angiopathy is one of the most commonly diagnosed dementias after Alzheimer's there at AIIMS. So this is a good question for INICET, your INICET exam, right? So try to remember this. So let's have a water break and come back and we will learn about frontotemporal dementias. Frontotemporal dementias. Frontotemporal dementias, FTD, or we also sometimes call it as FTLD, where L stands for lobar degeneration. Frontotemporal lobar degeneration. So FTLD is more like a pathological term, while FTD is more like a clinical term. Okay, so frontotemporal dementia. Now, as the name suggests, frontal lobe is involved. When frontal lobe gets involved, insight goes, judgment goes, there are behavioral changes, lots and lots of those. There is aggression. Right. And then there's a personality change. कि पहले तो बहुत शांत रहते थे, अभी बहुत गुस्से में रहते हैं. So there is a personality change. When temporal lobe gets involved, there is forgetfulness. And there is speech involvement. So it can be aphasia, it can be lethargy, usually aphasia because FTD again is a cortical dementia. Right. Now when we talk about FTD, we usually talk about the behavioral variant of FTD. So what are the variants? What are the variants of FTD? So one is a behavioral variant of FTD, जिसके बारे में हमने अभी बात की, which we just talked about. So behavioral variant of FTD is the most common type of FTD. Then we have PPA, which is a primary progressive aphasia, and then we have FTD ALS. Now, FTD-ALS is a combination of FTD along with amyotrophic lateral sclerosis. So, a patient with thinning of limbs, muscle loss, wasting, fasciculations, and behavioral changes in memory loss, you can think of FTD-ALS. It starts very early. So, FTD is not a disease of, is not a dementia of elderly. It usually starts after 50 years of age. 50 years of age. It starts quite early. Starts quite early. It also presents with food fadism in some patients. So what happens is that the food habits change. People who do not like to eat sweets or sugary substances, they are taking so many of sugary substances or having sugar cravings. That is known as food fadism. So that is also seen, those altered food habits are also sometimes a feature of FTD. So FTD ALS C9 or 72 mutation. It is on chromosome 9. Chromosome 9, a gene on chromosome 9, right? So try to remember that. Now, when we talk about primary progressive aphasia, we have a semantic variant and we have an agrammatic variant. Now, as the name suggests, agrammatic means the grammar is gone. So, for example, if I say the sky is blue, they will not say that. They will say sky blue. They will miss out the phonemes and the morphemes in the sentences. Then, if we talk about semantic, now semantics means concepts. They will forget that the sky is blue, right? We know when the word sky comes to my mind, blue automatically comes to my mind. I have a picture in my mind that the sky is blue, or the water is transparent, or water is tasteless. So these are concepts that are gone. So when you talk to patients with semantic aphasia, you get a feeling that the patient is not having an idea about the concepts, about various things. For example, a rainbow comes out when there is rain as well as sun. They will forget that. Now, these are simple things that we learn with age. People start forgetting these things when they have primary progressive aphasia, along with the behavioral changes. So, that is a PPA variant of FTD. That is a PPA variant of FTD. Now, for your exam, you need to remember the age and you need to remember the gene for FTD ALS. These are the two things you need to remember. But yes, try to remember everything else also in order to look at patients, and it will help you in your OPDs too. And also in your exam, you should have an idea about various uh, dementias of how they present. And FTD and Alzheimer's are one of the most common dementias that are there, right? The pathology that is involved, the pathological bodies that are involved in FTD are TDP43, then we have tau, and we have FUS, fused in sarcoma protein, FUS, fused protein, right? If we talk about vascular dementia, now vascular dementia is more about vessel involvement. So the small vessel disease, the periventricular white matter changes that we find in hypertensive patients, diabetic patients, recurrent stroke patients, they can have a step ladder pattern of memory loss. Like this stroke happened, they had aphasia, then another stroke happened, they had memory loss, another stroke happened. So that is vascular dementia. That is a step ladder pattern of vascular dementia. It is also known as Binswanger's disease. That's all you need to remember for vascular dementia for now. Now, I want to tell you about the cognitive domains and the lobes to give you a general idea about the various lobes in the brain and the functions attached to the lobes. And we will also talk about the Broadman areas. Cognitive domains, right? So, dementia is not only memory, there are 6 cognitive domains. The mnemonic to remember is LLPEX. LLPEX. L is language. The second L is learning and memory. P is perceptual. E is executive function. C is complex attention. S is social cognition. So these are the 6. Language, learning and memory, perceptual, complex attention, executive function, social cognition, right? So when we talk about language, there can be different aphasias. We are going to talk about different aphasias. Usually language is about C or NF, that is comprehension, repetition, naming and fluency, right? So comprehension, repetition, naming and fluency, we'll talk about this in detail in another 5 minutes. Give me 5 minutes. Memory is forgetfulness, memory loss. So memory loss is a small part of dementia, remember that. Perceptual means again the brain's GPS, directions, left right orientation, our body's orientation in space, or other objects' orientation in space. So finding ways, finding directions to the washroom, to the kitchen, to the park, to the shopping mall, that is all included in perception. Complex attention is when you tell them about something and they feel lost, right? So they don't seem to be attentive. But then this is because one of the lobes, the frontal lobe, is affected. Sorry. When we talk about executive function, we are talking more about planning. You test an executive function for a patient by asking them to do something complex or something they're used to. For example, cooking. A person who has been cooking all her life now forgets to put certain ingredients or forgets how much of salt was supposed to be there, or do I need to put the tea leaves first or the sugar first or water first, or I need to boil the water first. So they miss out on steps doing something that they are very much used to, and that is what is executive dysfunction. Somebody who was able to go for shopping, carry out all the shopping things for many years is now not able to do that. He's forgetting things, he's misplacing things. That is an executive dysfunction. By social cognition, we mean we have an idea how we need to behave socially. I know that if I'm not supposed to scream at people, I'm not supposed to laugh at somebody when they are telling me a sad news. So when that is lost, that is because the social cognition part of the cognitive domain is gone, and this is mostly related to the frontal lobe. So social cognition also presents like people say that patient came out of washroom without any clothes, forgot to wear clothes, and did not feel awkward about it. Secondly, patient went into the room and peed or urinated in the room, not in the washroom. So these are certain examples how patients do present. They do present like that. Trust me, I've seen patients. I've taken histories of many dementia patients, like countless patients, and these are the features that are actually there. So it is important to know this. Now, all domains are related to some lobes. So we need to know the lobes. We need to know the lobes of the brain and the functions connected with various lobes of the brain. So let's learn about the lobar functions. And this is again important for your NEET PG as well as your INICET exam. So lobar function. So we talk about frontal lobe, we talk about temporal lobe, we will talk about the parietal lobe, we will talk about the occipital lobe, and then we'll talk about the aphasias, right? So when we talk about frontal lobe, now social cognition is a function of the frontal lobe. Insight and judgment about right and wrong, a part of Frontal lobe. Behavior, a part of frontal lobe. Our personality, a part of frontal lobe. You don't need to note down everything. I've written everything in my notes, and my notes are also available for, as part of the course. So go ahead and go through the notes too, along with the videos. If you have the notes while I'm taking the lecture, I think it will be better for you to comprehend the lecture if you have gone through the notes before, or if you have notes in your hands while you are doing this. So okay, and then we have language. So we have Broca's area in frontal lobe. Now Broca's area is in the inferior frontal gyrus. It is in the inferior frontal gyrus. Please remember that. Okay. Executive function, again a part of frontal lobe. Executive function, again a part of frontal lobe. Now temporal lobe is about memory. Temporal lobe is about language. Wernicke's area, superior temporal gyrus, Wernicke's area. Papez circuit, hippocampus. And again hearing. Right, so that is temporal lobe. Parietal lobe is about construction, is about the visual spatial orientation. You ask the patient to draw a clock. You ask the patient to draw a clock and you tell him to show you a time. Patient will not be able to do it if the parietal lobe is involved, because this construction or visual spatial orientation, like there are 4 numbers at 90-degree angles. It's something that is given to us by parietal lobe, that is governed by our parietal lobe. And when parietal lobe gets affected, for example, in Alzheimer's, the clock drawing goes away. Right, so that is one thing. Occipital is about vision, it's about depth, optic ataxia, and yes, of course, apraxia, again a feature of parietal lobe. Now, apraxia means that a person is not able to do a motor task despite normal power. The patient's motor system is okay, but the wiring from the brain, the signal from the brain is not okay. So that is what is apraxia. So to test apraxia, you can ask patient to mimic how to blow a candle. You can ask patient for another motor task, like try to light a matchstick, or you can ask the patient to take a paper, try to fold it 3 times and then give it back. So there are 3 instructions, there are 3 steps. A person with a parietal lobe involvement, like in Alzheimer's or posterior cortical atrophy or in CJD, person will not be able to do that, right? So that is what is parietal lobe is about. Optic ataxia means that the vision is okay, but the person is still not able to figure out where is the object placed in space. That is optic ataxia. Then there is oculomotor apraxia. An important feature of PSP, progressive supranuclear palsy. PSP, it's an atypical Parkinson's disease, PSP. Right, so oculomotor apraxia means that the patient's eye movements are okay, but if he's asked, if you command him to look to his left or right, he will not be able to do that because he's not able to follow the commands. He's not able to comprehend your commands. But in case a door on his left opens, he will look at the door and he will know that it is on my left, and his vision will be okay. He will know who entered. So that is oculomotor apraxia. Now these are the main functions, these are the main lobar functions that we have. I have written down and drawn all the Brodmann areas also in my notes. So please go through the notes. I have written all the Brodmann areas. The Brodmann areas will be asked in exams, right? So it is something that you need to learn. It is not something that can be taught, right? कुछ चीजें मेडिसिन में ऐसी हैं which you need to learn, right? So you need to learn that Brodmann area 4 is that, 8 is about that, frontal eye field and this and that. So you need to remember that. Wernicke's area, area 22, you need to remember that. So please go through the notes to know about all the broadband areas. And as far as certain other important questions go, so there is something known as a Gerstmann syndrome. I think you all must have heard about it. Gerstmann syndrome, right? So Gerstmann syndrome happens because of angular gyrus involvement. Angular gyrus is a part of our parietal lobe. And what are the features of Gerstmann syndrome? So there are 4 features. I'll draw a rectangle and tell you there are 4 features. One is acalculia. Calculation is not there. Then there is agraphia. The writing is also not okay. Because why the writing is not okay is because, again, see, I told you parietal lobe is about visual spatial perception or orientation. The person doesn't know that I have to start from left, go to the right, or I have to keep spaces in between words, and that is what the writing differences are there in this Gerstmann syndrome. Then there is finger agnosia, not able to recognize fingers, which finger. And then there is the right left disorientation, right left disorientation. You can try to remember this with a mnemonic ARF. Doggies कहते हैं ARF. So you can remember it like that. AARF. So see, acalculia, A, then another agraphia, then R is right left disorientation, and F is finger agnosia. So please remember Gerstmann syndrome with this mnemonic ARF. Right. Then there are certain previous year questions that I have written in my notes too. Let us discuss about these questions too. In another 5 minutes, let's take a water break. Let's discuss all these questions. The previous year questions, right? So number 1, cortical versus subcortical. Cortical versus subcortical dementia. Okay. First, let me write all the questions, then we'll discuss the answers. Okay. So number 1 is cortical versus subcortical. Number 2, again, tauopathy versus synucleinopathy. Number 3, parts of hippocampus. Parts of hippocampus. Number 4, the 4 A's of Alzheimer's. The 4 A's of Alzheimer's disease. Then number 5, disease with loss of cortical neurons. Okay, so tauopathy we know ACPF, right? And synucleinopathies we know we had DLB, so padho daro mat, PDM. So DLB, PDD and MSA. Now parts of hippocampus are important to remember. Parts of hippocampus are hippocampal gyrus that we know, dentate gyrus, a subiculum, hippocampus proper and entorhinal cortex. So how can we remember this? How can we remember this? Yes, I remembered it with a mnemonic dash, DESH. So we have a dentate gyrus. We have a dentate gyrus. Please remember dentate nucleus is a part of cerebellum, but dentate gyrus is a part of hippocampus. So dentate gyrus, we have entorhinal cortex, we have a subiculum, and we have a hippocampus proper. We have a hippocampus proper, right? Now, what are the 4 A's of AD? So we should know this: agnosia, apraxia, Acalculia is not a part of Alzheimer's. So that is one of the questions that I read in your papers. Is acalculia a part of Alzheimer's? The answer was no. And they had given one more question was there where they had given 4 MCQs and they asked 4 options and they asked which one is not a feature of AD. So acalculia is not a part. So agnosia, apraxia, aphasia and amnesia. Aphasia and amnesia. Agnosia, apraxia, aphasia, and amnesia. Now, disease with loss of cortical neurons only tells me that they're trying to ask a cortical cause of dementia, a cortical dementia. And we know that in cortical dementias, we have dementias like Alzheimer's, Pick's disease, and CBD. So the answer here will be CBD because HD is a subcortical dementia, PTD is a subcortical dementia, PMLA is a subcortical dementia. We have already discussed about all of that. What are the lobes that are affected in Alzheimer's? There are 2 lobes, temporal and parietal. So the temporal lobe and the parietal lobes are affected in Alzheimer's. Causes of reversible dementia. So please remember B12 deficiency, hypothyroidism, any infection, and SOL. Right? For example, sometimes temporal lobe meningiomas lead to certain features of language and memory impairment. Patient presents with dementia, we get an MRI done. If it is a symptomatic meningioma, we need to remove it. So if the meningioma is causing a space occupying pressure or a symptom, we need to remove that. Otherwise, we can monitor meningiomas too. So that is one. Reversible dementias. Then we have B1 deficiency, niacin deficiency. So B1, B3, and B12. Then we have NPH. Then we have SDH, subdural hemorrhage, NPH, infection, an abscess formation, a tumor. All these are reversible causes of dementia. Whatever is a degenerative cause, like a progressive degeneration of neuronal cells, is not a reversible cause. For example, Alzheimer's, irreversible, CVD, irreversible, but everything else is reversible dementia, right? So please remember that. Now, we talk about normal pressure hydrocephalus. We have a triad. You can remember the triad with the mnemonic mug, 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 like a mug of coffee. So M here is for memory loss, G is for gait impairment, and U is for urinary abnormalities. So mug, right? We typically have a magnetic gait in NPH. We typically have a magnetic gait in NPH. In NPH, we have, so there is a ventriculomegaly. There is a ventriculomegaly. In NPH, there is a, this is an axial section. In NPH, there is a ventriculomegaly. Now, the distance between the diameter between the 2 frontal lobes, maximum width of frontal horns of lateral ventricle, and divided by the maximum inner skull diameter, okay, A by B, gives us Evans index. And if it is more than 0.3, it indicates NPH. Sometimes there is a sylvian fissure opening too. It is known as box scarring. It is known as box scarring. Typical term used for NPH. Right? And the treatment is, of course, a shunt. A treatment is a shunt. You shunt the CSF, the person will be okay. So we usually do a tap test. We take out at least 50 to 60 ml of CSF from the patient, and then we observe, is there a gait change, is there a change in the memory or not. We observe. If there is a change, we go ahead with the shunting procedure, and patients do improve with shunts. Now moving on to 2 or 3 more topics or questions, important questions from this chapter. One is MMSC. Beta, please learn MMSC, okay? So I will not show you the chart of MMSC. You will have that available in your books. It's given in Harris and it's there on Google. What I want to tell you are the cutoffs. So 24 to 30 is normal. 18 to 24 is mild cognitive impairment. 10 to 17 is moderate. cognitive impairment. Less than 10 is a severe cognitive impairment. Now, in educated people, less than 24 is suggest dementia. But in people who have not studied till 7th standard, less than 19 is known as dementia. So we decrease the cutoff for them. This is for educated people, and this is for people who have not cleared their till their 7th standard exam too. So this is the cutoff for MMSE, 24 and 19. Please try to remember this. Then let's learn about aphasias, right? Let's learn about aphasias. Where did the aphasias go?